Hi guys, so I thought I would do a very quick video for you guys concerning growth and development. I know I always say that this is going to be a quick video, then it ends up being 30 minutes. But apologies, there's a lot to talk about when it comes to medicine. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at growth and development in view of pediatrics. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab your piece of paper, grab your pen, and let's go. In view of the new style of the lectures, here's our single best answer. Consider the following factors. 1. Pincer grasp. 2. Social smile. 3. Crawling. 4. Transfers of objects from one hand to the other. The correct sequence in developmental milestones during the first year of life is A. 1, 2, 3, 4. B. 2, 4, 3, 1. C. 1, 4, 3, 2. D. 2, 1, 3, 4. Keep this question in mind. Write your answer down right now. Scream your answer at the screen. I will give you the answer at the end of the video. So, what do we mean by growth? Remember that growth is pretty much an essential feature that's going to be distinguishing a child from an adult. Remember, in pediatrics, you don't think of children as mini adults because they are going to undergo growth. They're going to undergo development. So growth is a process where there is an increase, a net increase in the size or mass of tissue. Now, this is going to be largely attributed to the multiplication of the cells and the increase in the intracellular substance. So things like hypertrophy or expansion of cell size actually contributes to a lesser extent to the process of growth. And remember that this process of growth is going to be developing, or rather beginning at the time of conception, and it continues throughout the child's life and as they mature into an adult. And development, on the other hand, is pretty much maturation of functions. So this is going to be relating to the maturation and the myelination of the nervous system. So it indicates acquisition of various skills for optimal functioning as an individual. So remember that growth and development are going to be occurring concurrently, and they're going to be closely related, such that if you have a factor that's affecting one of them, it more or less invariably is going to affect the other. So if you have something affecting growth, it may also affect development of the child. So we'll begin with growth. So remember that there are some specific periods in which a child's life where they grow rapidly, where they grow steadily, and where the growth actually decelerates. So when you look at the fetus, I'll look at these definitions of what a fetus is, what an embryo is in the next slide. So when you look at a fetus usually grows fast, especially in the first half of gestation. Thereafter, it's going to be slowing down its growth rate until the baby is born. Then in the early postnatal period, the growth velocity is also quite high, especially in the first few months. Then thereafter, it's going to slow down, and then you have a steady growth rate throughout mid-childhood. Another growth spurt is going to be reached at puberty, where there's accelerated growth. Then thereafter, it decelerates until it ceases altogether. But generally, the rule of thumb is that the body growth is quite rapid during fetal life. It's quite rapid during the first 1 and 2 years of postnatal life, and it's also quite rapid during puberty. So those are the three important points in a person's life where growth is actually quite significant. In the years in between mid-childhood, the somatic growth velocity is actually going to relatively slow down. And remember that the order of growth is happening in a cephalocaudal direction. It's also happening from distal to proximal. What do I mean? So in the fetal life, the growth of the head is going to be occurring first, followed by the growth of the neck. Then the arms are going to grow before the legs. Then, of course, the distal parts of the body, such as the hands, will increase in size before the upper arm actually begins to increase in size. And in postnatal life, growth of the head actually slows down and the limbs continue to grow quite rapidly in postnatal life. Here are some definitions that I want you to keep in mind. So in ovum is the period between 0 to 14 days of gestation. An embryo is from 14 days to 9 weeks. A fetus is 9 weeks up until birth. Then the perinatal period is 22 weeks to 7 days after birth. Then, of course, in the postnatal period, a newborn is in the first 4 weeks of birth. Infancy is the first year. Toddler is 1 year to 3 years. Preschool going child is 3 years to 6 years. School going child is 6 years to 12 years. And adolescence is, of course, from the early adolescence 10 to 13, but most people actually put it at 13. Then middle adolescence 14 to 16. Late adolescence is 17 to 20. And beyond 20, you're considered as an adult, I guess. So how do we assess physical growth? There is what are known as anthropometric measurements. So the weight, the height, the head circumference, which is also referred to as the occipital-frontal circumference, the chest circumference, and the middle upper arm circumference. So whenever you are dealing with a pediatric patient, you want to measure these anthropometric measurements. So it's actually difficult to precisely define the normal growth pattern. So what we're going to be actually using is an average of readings that we're going to be obtaining from a group of individuals that we deem to be healthy. And of course, there is some variation. So there is some range, and you can't say that because this person is below the mean weight of a child that's supposed to be in Zambia, they're underweight. No, we actually have a range. If you look at the growth card and the under 5 card, which I actually talked about earlier on the channel, you will see that there are percentiles and there are ranges. So most healthy children are going to maintain their growth percentile on the growth chart as the years pass by. So significant deviation of the child past these percentiles is going to be attributed to things like recent illness. It could even be overnutrition or undernutrition. If they cross 2 major percentiles, then you should be worried. So remember that it's important to take into account the gestational age of the infants that are born prematurely. So if it's a premature child, you should subtract the duration of the prematurity from the infant's chronological age. So this is, of course, this correction is not needed when a child reaches 2 years. You don't need to correct this. You just take it as it is. So we'll begin with weight. So this is pretty much how much the child is going to be weighing. So the weight of a child is supposed to be taken when the child is nude or they're minimally or lightly dressed. And you can measure it accurately with a lever or an electronic type of weight scale. Spring balances are actually less accurate. This is I think it should be a triple beam balance. Is one of the scales that you can use to measure the weight of the child. And remember that the weight scales must have a minimum unit of 100 grams, and you should place the child in the center of the pan. You should correct any zero errors before you measure, so make sure that it's starting at 0. If it's not starting at 0, you should take this into account and subtract the units or subtract the amount from 0 from your final weight. Take serial measurements and then, of course, do an average. And remember that the average birth weight of a neonate is roughly 3 kg, so between 2.5 to 3.5 kilograms. So during the first few days of birth, the child is actually going to lose this extracellular fluid, about 10% of their body weight. And most of the infants are actually going to be regaining this in about 10 days. And subsequently, they're going to be gaining weight at an approximate rate of about 30 grams per day for the first 3 months. So 30 grams per day for the first 3 months, 20 grams per day for the 3 months to 6 months, and 10 grams per day for 6 months to 12 months. But I know most of you are not going to remember those things. It's very important that you do remember those growth patterns, because you're able to calculate how much a child is supposed to weigh from birth up until maybe, let's say, they are 8 months or 9 months. But here are some formulae that you can use and that you can actually keep in mind. So this is the best guess formula. So if a child is less than 1 year, you say the age in months plus 9 divided by 2. So let me give you an example. Suppose they are 9 months. So 9 plus 9 will give you 18. 18 divided by 2 will give you 9. So the child should roughly be around 9 kilograms using this formula. We can also use the Advanced Pediatric Life Support or life support system formula. So 0.5 multiplied by the age in months plus 4. So if we say 9 divided by 0 or multiplied by 0.5, so that should be about 4.5 plus 4, that gives you around 8.5. So there's a difference of 0.5 when you're using the best guess formula with this formula. And then of course it's the same for the weight formula. Those that are between 3 to 12 months, the age in months plus 9 divided by 2. Then for the children that are between 1 to 4 years, you say the age in years plus 5. Then you multiply your answer by 2. Suppose if someone is weighing, or rather someone is 3 years old. So 3 plus 5, that gives us 8. 8 times 2, that gives us 16. If we're using this formula, 2 times 3, that gives us, of course, 6. 6 plus 8, that gives us 14. Then if we're using this formula here, 2 times the age, which let's say 3 years, 2 times 3, that's 6. 6 plus 8, so this is the same thing as this, 14. Then if a child is between 5 to 14 years, it's just simply 4 multiplied by the age. So if they're 5 years, 4 multiplied by 5, that's 20. If you're using the Advanced Pediatric Life Support System formulae, that's 3 multiplied by 6. This one starts at 6, it doesn't start at 5. So 3 multiplied by 6, that gives us 18. Then plus 7, that should give us, I think, 25, if I'm not mistaken. Then if we look at the wage formula, this here is from, again, 7 to 12. So you'd say 7 multiplied by the age. So if it's 7 multiplied by 7, so that would give us 49. 49 minus 5, that would give us 44. 44 divided by 2, that would give us 22 kg. So the child would be 22 kg. So these are how you use these formulas. They're pretty much self-explanatory. I may have messed up on one or two of the calculations, but that's how you use the formulae. So here's another simple method. 1 year is equal to 10 kg, 3, 15, 5, 27, 25, 9, 30. As you can see, I'm moving by 2 years. From 1 year to 2 years, so they should be between 1 year to 3 years, they should be between 10 to 15 kg. Between 3 to 5 years, they should be between 15 to 20 kg. Between 5 to 7, they should be between 20 to 25 kg. 7 to 9, they should be between 25 to 30 kg. So you can actually keep this simple method in mind, and these are the different ways in which you can calculate the weight of a child in pediatrics. So what about the height and the length? Remember that the length is going to be recorded for children that are under the age of 2 years. So we should remove any hairpins, we should remove any braids, or the braids should be undone. Any bulky diapers should be removed. The child should be placed supine in what is known as a rigid measuring table or an infantometer, which is what is described here. So we're measuring the length using an infantometer. So you should actually make sure that the knees are gently straightened out, the head is flat, and the feet are well aligned, like that. So the child's head should be held firmly in position, in a fixed upright position, and against the headboard. Then of course the legs should be straightened and kept flat at right angles to the legs with the toes pointing upwards. Then of course the free end of the board should be brought in contact with the child's heels, and we should measure the length of the baby using the same infantometer. Remember that measuring the length of a child using when the child is lying on a mattress, not really a hardboard, or when a child is lying on a bed and you use your measuring tape, it's not really accurate, it's not really recommended. You should use an infantometer. Then you may use a stadiometer, which is measuring the standing height. So here for the standing height, the child is going to be standing pretty much upright. Their heels are going to be slightly separated so that their weight is evenly balanced on both feet. The heels, the buttocks, the shoulder blades, and the back should be all brought into contact with the vertical surface of the wall. Then, of course, the height should be measured with a rod or a stadiometer. And remember that the head should be placed in a certain position. So the child is going to be looking directly forward. And the Frankfurt plane, what is this Frankfurt plane? It's just simply a line that's going to be joining the flow of the external auditory meatus, which is the opening of the ear, to the lower margin of the orbit. So that should be at a horizontal line. So, and the ears should also be at the same level. And the head is going to be firmly placed against or compress the hair against the wall or against the backboard of this apparatus. And then, of course, you're able to measure the height of the child. Now, there are some length or height formulae that you can also use. Remember that when a child is born, they are approximately about 50 centimeters at birth. At 3 months, you add a 10, so they're at 60 centimeters. At 6 months, another 10, they're at 70 centimeters. Then after they reach a year, 1 full year, they should be roughly around 76 centimeters. Because remember that growth is not really in a linear pattern, it's rather an exponential type of thing. So it's not a linear pattern. So you can't say that you keep adding 10 after every 3 months. That's not how it works. So at 1 year, they're about 76 centimeters. So now when they are between 2 years to 10 years, you can say the age multiplied by 6.5, then you add 76 to that. That's how you would calculate the length or the height. Then after the child is 4 years, just simply add 5 centimeters for each year until they reach 12 years. Then after this, the increments of height vary according to the age of onset of puberty. And of course, there are different growth patterns when puberty hits children. What about head circumference? Remember that here you must remove any hair ornaments, you must remove any braids that should be undone, and you should use non-stretchable, non-elastic measuring tape. And we should measure the maximum circumference from the occipital protuberance above the supraorbital ridge of the forehead, and you should actually cross the tape. Just like this is being depicted in this picture, the tape should cross each other. And of course, remember that the head grows rapidly, especially in the first year of infancy. And this is because in the first 2 years, actually, that's where you have the maximum growth of the brain. And the head growth actually slows afterwards. So at birth, the head circumference is a range of 34 to 37 with an average of 35. The first year, it increases by 10 centimeters. So it's going to increase to about 45 centimeters. That's between 44 and 47 centimeters. So within the first 3 months, it increases by 2 centimeters per month. From 3 months to 6 months, it increases by 1 centimeter per month. From 6 months to 12 months, it increases by 0.5 centimeters per month. That's very easy to remember. Then at 12 years, it has reached a circumference of about 55 centimeters. So that's a 10 centimeter increase. So keep this in mind because they do ask you these things when you are dealing with children, especially on your long case. They do ask you these things on your theory exams. And you also have your anterior fontanelle, which is diamond in shape, and a posterior fontanelle, which is deltoid in shape. The anterior fontanelle closes at 18 months roughly, and the posterior fontanelle closes by around 3 months. What about chest circumference? This is going to be measured at the level of the nipples, midway between inspiration and expiration. Again, use a crossed method of the tape. As you can see here, the tapes are crossing. You're not overlaying them on top of each other. They're crossing each other. Then, of course, the circumference of the chest is about 3 centimeters less than that of the head. So roughly around 32 centimeters. Then the circumference of the head and the chest are almost equal when the child is 1 year. So it's roughly around 45 centimeters. Then thereafter, the chest circumference exceeds the head circumference. But of course, we don't routinely measure the chest circumference every time the child comes in to the under 5 clinic. Then we also do measure middle upper arm circumference. This is very important, especially if you're dealing with a malnourished child. So there are some landmarks that you're going to be actually using. So the first landmark is going to be your tip of the acromion process. That's from the scapula. Then, of course, the olecranon here from the ulna. So halfway, that's where you should actually measure this. So you should also use a crossed method when you're measuring this. And remember that if the mid-upper arm circumference is less than 11.5, then that's usually pointing towards severe acute malnutrition. And remember that your tape should be non-elastic, shouldn't be able to stretch. What about body mass index? So this is calculated using the weight of the child in kilograms divided by the height in meters squared. So you square the height in meters. So the BMI is actually used to assess obesity, and a BMI that's at or even above 95 percentile of age or more than 30 kg per square meter, you consider this as obesity. So here are some of the approximate values. Remember that the weight, the height, the head circumference up until a child is roughly around 5 years. The sexual maturity, we measure these things routinely at the under 5 clinic to ensure that the child is growing and they are developing. Then we plot these on the standard growth curves, which represent the normal values for the age of 95% of the children. And then we should plot the weight, the height. Some under 5 cards even have the body mass index and the head circumference. Then, of course, there are some special growth charts that are going to be existing for children that have particular conditions like achondroplasia, which is dwarfism, and Down's syndrome. But here are some of the approximate values to keep in mind. So at birth, the weight, the height, the head circumference at 6 months, 1 year, 2 years, 3 years, and 4 years. And I think this is very, very self-explanatory. Now we'll move on to the next segment of this lecture, which is pretty much development. Now remember that development refers to maturation of functions and acquisition of various skills for optimal functioning of an individual. So remember that the maturation and the myelination of the nervous system is going to be reflected in a sequential manner of which we attain these type of achievements, which we call developmental milestones. These are very important because we can easily identify events because they are a continuous process. For example, before a child can sit, they should be able to roll over in bed. They should be able to sit afterwards. Afterwards, they should be able to reach for objects. They should be able to point for objects. They should be able to crawl. They should be able to cruise. They should be able to walk. They should be able to run and eventually jump. So they happen in a sequential manner. And remember that increasingly complex skills are going to be learnt, and this is going to be matching the formation of new synapses in the brain. Then with global development, or global development is rather a global process, and it's going to be reflected by new motor activities that you are learning, language skills that you're learning, social and even cognitive skills. On the other hand, when you refer to intelligence, this is just pretty much a part of development that's going to be dealing with cognitive and adaptive behaviors. So it's just pretty much the ability to apply knowledge in order to manipulate one's environment, or to think abstractly, or to even refer to the aggregate or the global capacity of an individual to act purposeful or think rationally or even deal effectively with the environment. That's what we refer to as intelligence. So it's not just purely just memory. So what are some of the rules of development? So the first thing that I want you to keep in mind, these are very important because they can actually help you work out certain things when you're asked on your exams, how old do you think this child is? For example, they give you a scenario that a child is able to sit, they're able to transfer one object from one hand to another, and they have an immature pincer grasp. They are able to also give the social smile. How old do you think this child may be? You should be able to figure this out because of the rules of development. So number one thing is that development is always a continuous process. So it starts off in utero, and it's going to be progressing in an orderly manner until the child is mature. So the child has to go through all the developmental stages before a milestone is achieved. Remember that before you can sit, you should be able to roll in bed. Before you can stand, you should be able to sit. Before you can walk, you should be able to stand. Before you can run, you should be able to walk. Before you can jump, you should be able to run. So they happen in a sequential manner. This is very important, meaning that if a child is not able to sit, you don't expect them to walk. If a child is not able to attain head control in bed, you don't expect them to sit because they haven't yet achieved that milestone of being able to control their head. Then the development represents the functional maturation of the nervous system. I think I already alluded to this. And the sequence of attainment of milestones is the same in all children. Whether you're a child in Zambia, whether you're a child in the UK, the sequence of maturation is actually pretty much the same in all children that we see in the different countries. And remember that all infants are going to babble before they can speak words, and before they can sit, before they can stand. There may be some variations that may exist in the time and in the manner in which a child actually attains these developmental skills. But remember that the process of development progresses in a cephalocodal direction. What do I mean? Just like with growth, the head control usually precedes controlling of the trunk. Then this also precedes the ability for you to use your limbs. And then the control of the limbs occurs in a proximal to distal manner. This is different with growth. Remember, with growth, it happened from a distal to proximal manner. Here it happens in a proximal to distal manner, meaning that the hand you learn to use the hand first before you can actually use the fingers. Then there are some certain primitive reflexes that have to be lost before relevant milestones are attained. For example, the palmar grasp should be lost before a voluntary grasp is attained, and the asymmetric tone neck reflex has to disappear to allow the child to be able to turn over. Then the other rule is that the initial disorganized mass activity is gradually replaced by specific willful actions. For example, when you show a child a bright toy at 3 to 4 months, they're going to squeal very loudly, they're going to be excited, or their limbs are moving. Whereas when you show a 3 to 4 year old child, they'll just smile and maybe ask for the toy. So these things usually change as the child is developing. And then the last thing is that the development may be influenced by both intrinsic factors, for example, the child's physical characteristics, their state of health, their temperament, and even their genetic attributes. It may also be affected by extrinsic factors like their personality of the family members, the economic status, depression, or even mental illness of the caregivers, and even the availability of learning experiences in the environment or the cultural setting in which the child is born. So what are some of the domains of development that we'll look at? So these are pretty much, we're going to look at motor development. We'll divide it into two: gross motor skills, fine motor skills. Cognitive development, social and emotional development, hearing, speech, and language. And remember that the attainment of a particular skill depends on the achievement of an earlier skill. You need to attain a certain skill before you move on to the next one. And a delay in one of the developmental domains may actually impair the development of other domains. For example, it's very difficult if a child has difficulty in this problem-solving skills. For example, in the children that have cerebral palsy, who understand the concept of matching geometric forms, but they lack the physical ability to demonstrate this knowledge. So it means that even the cognitive capacity is going to be affected. And remember that information about the motor milestones should be obtained from your history as well as from observing during your physical examination. So we'll start with gross motor development. So this is going to be occurring in a cephalocaudal direction. The primitive reflexes should be suppressed. The child should develop postural tone, and of course they should develop secondary protective reflexes. What are some of these primitive reflexes that I want you to actually read up on after this lecture? The motor reflex, the grasping reflex, the stepping reflex, the asymmetric tone neck reflex. These must all disappear by 3 to 6 months before the head control is actually attained. Head control is roughly around 4 months. And before the child is actually able to independently sit, they are able to sit roughly between 6 to 8 months. So remember that each of these primitive reflexes usually requires a specific sensory stimulus to actually generate the stereotypical motor response. Infants with CNS lesions are actually going to be showing a stronger and more sustained primitive reflex. So when you're actually examining a newborn baby, if they actually depict these primitive reflexes very much, it could be an issue. So postural reactions like the parachute reaction are not present at birth. They are actually even acquired. So these reactions actually help facilitate the orientation of the body in space. They require complex interplay of both cerebral and cerebellar cortical adjustments to proprioception, visual, and even vestibular inputs. And of course, infants with CNS damage are going to have delays in development of postural reactions. So what are some of these milestones? So at birth, the child is just able to turn their head from side to side. After 2 to 3 months, the infant can lift their head when they are lying on a prone position, and the head usually lags. If you pull the infant with your arms, their head will lag behind. It's like it falls behind, like a door that has a very huge head and it's not being supported by the neck. At 4 months, the infant is able to roll over, and there is no head lag when you pull them to the supine position. Then the infant also pushes the chest up with the arms. Then by 6 months, the infant should be able to sit alone, and they should be able to lead the head when they're pulling up or they're pulled up to the supine position. By 9 months, the infant should be able to stand and cruise. Cruising is just simply like the infant will be holding on to the furniture and moving along the furniture. So they're able to cruise. By 1 year, the infant should be able to walk. So we actually consider that there is a delay in walking if a child reaches 18 months and they're not able to walk. So 18 months is a warning sign in a child who has been crawling as the early locomotor pattern. Then by 18 months, the child is able to climb onto a chair and walk up and down stairs. That's of course 2 feet per step. And then by 24 months. Then by 2.5 years, the child should actually be able to even stand on their tiptoes. They should be able to jump on both feet, and they should be able to kick a ball. By 3 years, the child should actually even be able to walk backwards. They should be able to ride a tricycle. Then there is further development in gross motor function and balance with age, and most children can actually participate in a variety of activities like swimming, skating, gymnastics, ball games by the age of 6 to 7 years. So this is where most professionals actually start getting serious with their stuff. So if you want your child to actually become a professional, start them at this year. So here are some of the reflexes. So we have primitive reflexes, the moral reflex, which is pretty much symmetrical abduction and extension of the arms with the trunk extension. So this is followed by adduction of the upper extremities. So this appears at birth. It disappears by 4 months. The hand grasp is just pretty much a reflex grasp of any object that is placed in the palm. This is at birth. It should disappear by 1 to 3 months. The atonic neck reflex, if the head is turned to one side, the arms and the legs extend on the same side and flex on the opposite side. So it's like this person is fencing. It's like they're pointing you with a sword. So this is present at 2 to 4 weeks and it disappears by 6 months. Then the rooting reflex, so they turn their head towards the same side as the stimulus is placed on the corner of the infant's mouth. For example, if the child feels that there's a boob that is touching my cheek, it moves its head towards the boob so that the nipple can get into the mouth. That's how I actually think of this rooting reflex. So this is seen at birth and it disappears by 6 months. Then you have some postural reflexes like the head righting reflex. There's the ability to keep the head vertical despite the body being tilted. The parachute reflex, which is just simply the outstretched arms and legs when the body is abruptly moved first in a downward direction. For example, you're holding the child and you make a motion like as if you're about to drop the child. You see that their arms and their legs are like someone who's falling. So this appears by 8 to 9 months and it persists. The head righting reflex also persists. What about the fine motor skills? So these are going to be involving the use of small muscles of the hand, and these fine motor skills are going to be progressing over the proximal muscles to control the distal muscles. Then, of course, during the first year of life, as balance and sitting in ambulatory positions improve, then the hands become more available for them to now manipulate these objects. So as the control with the distal muscles improves, they are able to reach and manipulate skills, and these are going to be enhancing. Then during the second year of life, the infant actually learns to use the objects as tools, so they can actually play with building blocks. At birth, the infant is just going to be having their hand tightly placed in a fist. By 3 to 4 months, the infant is able to bring their hands together in the midline and then to the mouth. By 4 to 5 months, they're able to reach for objects. By 6 to 7 months, they're able to rake objects with the whole hand, and they can even transfer objects from one hand to another. Then by 9 months, they can use the immature pincer grasp. This is just the ability to hold small objects between the thumb and the index finger. So that's a pincer. It's like you're making pincers. Then by 12 months, the pincer grip is actually matured. Then what are some red flags in motor development? So if there is fisting of the hands beyond 3 months, that is a very big problem. That's the earliest sign that you may get of a neuromotor problem. If the early rolling over, early pulling to stand instead of sitting, or persistent toe walking may actually indicate that this child may have spasticity. Then of course, certain postures like scissoring in a child with spasticity or a frog leg position in a hypotonic infant, these are usually clues to motor abnormalities. Then of course, early dominance before 18 months, where the child is just using one arm. This may be a sign of weakness of the opposite side and upper extremity associated with hemiparesis. So what are some of the things that can cause CNS injury and they can cause this motor delay? It could be spinal cord dysfunction, peripheral nerve pathologies, it could be motor end plate dysfunction, muscle disorders, metabolic disorders, sometimes neurodegenerative conditions. What about language skills? So remember that delays in language skills are more common than any other domain. And remember that receptive language is always more advanced than expressive language. So a child is usually going to be understanding 10 times as many words as the child can speak. If you tell them simple commands, they're able to follow those commands, but they can't really speak and repeat the commands back to you, but they're able to understand. So the language and the speech are actually not synonymous. Remember that language is the ability to communicate with symbols, signs, gestures, writing, and body language, while a speech is just vocal expression of language. So a window of opportunity for optimal language acquisition occurs during the first 2 years of life. So at birth, the child actually attunes to human voices and is able to even recognize the parent's voice. By 2 to 3 months, they are cooing. So this is just runs of vowels. They make musical sounds like ooh, ooh, ah, ah. By 6 months, they babble. So that's just mixing vowels and consonants like ba, 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 da, da, da. Then by 9 to 12 months, there's jargony. So there's babbling with mixed consonants, with inflections, with cadence. This is just pretty much mama, dada. It's non-specific. Then by 12 months, they're able to say by 1 year, they're able to say 1 to 3 words. So mama, dada, now it becomes rather specific. By 18 months, they can say 20 to 50 words. So usually it begins with 2-word phrases. By 2 months, they say these 2-word telegraphic sentences, mommy, come. And then 25 to 50% of the child's speech should be intelligible. Then by 3 years, they say about 3-word sentences. So more than 75% of the child's speech should be intelligible. So the differential diagnosis that can lead to speech and language delays, it could be global developmental delay or mental retardation. We want to refer to it as learning disability. It could be hearing impairment. Remember that hearing and language skills are closely related. It could be environmental deprivation, and there's not that much exposure. It could be a pervasive developmental disorder, including an autism spectrum disorder. What about cognitive development? So this is going to be involving skills like thinking, memory, learning, and problem solving. And remember that intellectual development depends on attention, information processing, and memory. So the infant's intelligence can actually be estimated by evaluating the problem solving and language milestones. So language is the single best indicator of intellectual potential. Maybe that's why they say that if you speak good languages or many languages, it's usually a sign of intelligence. But anyways, I'm not going to go into that argument. So by 3 months, they should be able to remember that gross motor skills correlate with poorly with cognitive potential. So by 3 months, the infant can move the object. By 6 months, the infant can imitate facial expressions and recognize strangers. By 9 months, they can actually imitate certain gestures. By 12 months, they can understand simple commands. By 24 months, they can actually identify shapes, colors, and they can even count. So what are some of the red flags in cognitive development? You could have some language development estimate or verbal intelligence, whereas problem-solving skills estimate nonverbal intelligence. So if the skills are delayed, there's going to be significant it's going to affect the language. It's going to affect problem solving skills or problem solving domains. So mental retardation should be considered. If only the language skills are delayed, then hearing impairment or communication disorder should be considered. If only the problem solving skills are delayed, then visual or even fine motor problems are going to be interfering with the ability of the child to manipulate certain tasks. Then if there's significant discrepancy between the language and the problem-solving skills, then the child is at risk of a learning disability. What about social skills? So this is just the ability to interact with other people in the environment. So development of social skills is dependent on the cultural and environmental factors. So milestones are going to be including attachment, which is pretty much bonding with a primary caregiver, and this begins at birth. They develop empathy, or developing empathy is actually critical during the first 3 years of life. A sense of self and independence is actually just the process of separation and individualization that begins at 15 months. So they should be able to be dependent or independent by this. Then social play, so the toddlers are actually going to be exhibiting parallel play during the first 2 years of life. They learn to play together and share at about 3 years of age. So here's a high yield table to summarize everything that I have talked about in the lecture. You may actually pause the video, get a screenshot of this. It will help you. It's a very high yield table. Then here's a warm-up question, which is a single best answer. Consider the following factors: the pincer grasp, social smile, crawling, transferring objects from one hand to another. The correct sequence in developmental milestones during the first year of life is... So the first thing that comes here, the earliest thing that I can actually pick up is a social smile. This happens very early. So it means that option A is out, option C is out. We only leave with option B and option D. So option D here is the social smile followed by pincer grasp. So you can't have a pincer grasp if you're not able to transfer objects from one hand to another. So this option doesn't make sense, only leaving B as the option here. So you first have a social smile, then you're able to transfer objects from one hand to another, then you're able to crawl, then you're able to have that pincer grasp. I really hope you enjoyed learning this and you now have a better understanding on growth and development. If you did, consider subscribing to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Drop a comment, drop a like. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.